everybody, I'm Al Rochelle, and this segment we're going to talk about two things kind of combined. We're talking about urology and gastroenterology and how it all pulls together and have a unique combination that are celebrating their wedding anniversary, even as we're doing this right now. Thank you so much, Gisela and Chelimsky. Thank you so much for your time with us.
Thank you for having me.
So tell me just a little bit about your backgrounds, each of you. Give me about 30 seconds of your background, 30 seconds of your background.
Sure.
So I am a pediatric gastroenterologist, and over the years, even during my fellowship, I started working in the autonomic nervous system. Mm-hmm. That was many, many years ago. That was like in '94. And at that point, there was no work on the autonomic nervous system and the gastrointestinal tract in pediatrics. So pretty much I was a pioneer in that.
Oh, gosh.
And in 2006, we started working together, combining even our clinics. Tom is a neurologist. He will talk a little bit later, but we started seeing kids with autonomic disorders, in abdominal pain, in gastrointestinal symptoms. And what we thought that was going to be a half-a-day clinic once a month ended being our life. This is all we do right now. And we see kids from all over the country that come with gastrointestinal disorders and autonomic disorders.
Now, it's funny that you should mention this. We have 4 kids, and one of our children for a couple of years had really similar. And here's what this is how far we've come in medicine. They go, well, it's just growing pains. He'll grow out of it. And so for 2 years, he, I think, suffered a lot through it, and eventually did get through it. Is it because we're now seeing more of these things, or is it because of research like you that we say, now we can identify what it is and now we can do something about it?
You know, I think it's both. It's interesting. We many times thought, okay, is this a disorder of this time of development where everything is in a hurry, where the kids are overbooked? But we were reading the biography of the Wrights brother.
Yeah.
And so that was 1890 something,
right?
And one of the boys ended having one of the syndromes, and he was bedridden for 2 years.
Oh gosh!
With they call it, and maybe I'm not quoting it correctly, histrionic disorder, but he had gastrointestinal symptoms, migraines, nausea, and obviously they didn't know what it was, and it took him 2 or 3 years to get better.
Wow!
So it's not a problem of this age. I think it was there all the time, and we just didn't recognize it.
So before we talk about the urology side of things, and Tom, we're not avoiding you because you're going to get your time too here. So are we seeing this more often now, or is it like a lot of things, it was always there, now we have just named it and we know how to attack it?
I don't know that we know the data for that, but I think that it was always there, and I think that now we are recognizing it. But I still think that a lot of, and I'm going to talk about the children or adolescents, a lot of adolescents get told, oh, you have nothing, it's all in your head, just push through, you just don't want to go to school, rather than understanding that the symptoms are real and they're suffering.
You're making me feel guilty because those are all lines that I used on my kids, and I'm thanking the Lord that they didn't have these other disorders. But I mean,
there is some good thing to push through these disorders, because if you don't continue your activities, and I'm talking about the adolescents now,
sure,
usually you get more disabled, which is a complicated message for parents, because you want to be a loving, caring parent. Mm-hmm. But on the other hand, if you allow them to stop doing stuff, the less you do, the worse you get. So you should not feel guilty.
well, thank you. That's good to know. So tell me about per age group. Does this happen more commonly, 3 to 6, 6 to 14? What age groups?
We see it after puberty. So okay. 12, 13-year-old, predominantly females. There are some males, but I would say, and this is not a statistic, that
right, just
but
ballpark.
About 95% or 90% of my patients are females.
Now, is this something that it's an autonomic problem, right? Is it still or not? Yes, no, do we know?
I would count it as an autonomic disorder, although I think that the NIH, the National Institute of Health, now puts this under the umbrella of chronic overlapping pain conditions, because what's happening is that, and I don't know if your child had this, it's not just a belly pain. Sometimes it's migraines, it's fatigue, it's nausea, it's aches and pains all over the body. So for a long time this was called functional disorders, And to me, that has the negative connotation that, oh, there is nothing wrong with you.
Yeah, the word disorder, though.
And functional means we can't find anything. You know, we do a scope is normal, we do blood tests is normal, we do CT scans is normal. So you have nothing. You're making this up. And this term of chronic overlapping pain condition just means that there is a disorder where a lot of symptoms come together, and it's not telling you anything about what's the cause or dismissing it. We believe, and here is where the combination of neurology and GI plays together, that this is a disorder of the brain, not a psychological disorder, but a brain disorder. And we can talk more about that.
What are some of the things that a urologist might see in a practice that might indicate that autonomic nervous system failure or dysfunction might be related to it somehow?
My name is Tom Chelimsky. I'm a neurologist, and we have two broad areas of study. One is, I would say, the pediatric gastroenterology, and I remember when we started our first clinic together in 2006, the next clinic was booked with 2 people from out of town, and we asked, how could that be? We never advertised that we're doing this, and the internet was up and running, and people found out very quickly about this combination. So this is a good way to approach these disorders because we've got the gut covered and the brain covered, and we talk about how the brain and gut interact, which is where we think, back to your question about the autonomic nervous system, where we think the autonomic nervous system is playing a role. Is the autonomic nervous system actually damaged or at fault? Maybe not. Maybe just the messaging between the brain and the body are not working very well. So we sometimes talk about these particular disorders in kids as being disorders of software, in contrast to disorders of hardware. So we use that kind of an analogy.
Oh yeah, that's excellent.
So this is a programming issue. Your brain or your nerves need some reprogramming, but they're not actually damaged. In contrast to some of the adult disorders that happen later in life, like Parkinson's disease or multiple system atrophy, we term those structural or hardware disorders. The autonomic nervous system is actually being damaged. So it's much more difficult to put a new hard drive in, for example, since we don't know how to make hard drives, compared to reprogramming that relates, and we'll talk a little bit later how to reprogram, but there are ways of reprogramming the brain. One of them is what Gisela just talked about, which is that you just have to continue what you're doing, continue exercising, continue your life. If you don't, then you actually enhance the software abnormalities.
Now, what I'm thinking in my head is that, and I think anybody who's been a parent or anybody, sometimes when you get excited, like when I knew I was going to do all these interviews with all you doctors, I got a little bit of pain in my stomach. So there was some kind of connection between your brain, and for some people it's a lot more severe that they can't function. Now that would be considered a normal function of, when does it snap from being a normal function to all of a sudden it's something more severe than just normal?
Well, you're asking a great question. That's a wonderful question. What's normal and what's abnormal? In this particular realm, it becomes abnormal when it affects your daily life. So we don't have an arbitrary cutoff because we don't have any biological markers. But when the syndrome you're describing, what sounds maybe like a little bit of IBS, irritable bowel syndrome.
Well, sure, yeah, right. Which oftentimes is what these people are diagnosed with, or they think that's what it is. Yeah.
And that's correct. That's the correct diagnosis.
And so when does it become abnormal? It becomes abnormal when you can't perform your daily job, enjoy your daily life, and it's probably in the realm of normality when it's a little bit of a symptom that you just manage yourself, but it's probably still irritable bowel syndrome.
Well, some of this almost sounds like behavior modification in a way, but if it's not, is that right?
That is correct. That's part of how we manage. So, talking about the functional disorders or the chronic overlapping pain conditions, and talking about the teens, the way we manage those patients is with, I would say, mainly 3 things. One is doing cognitive behavioral therapy. And I'm not a psychologist, and Tom can help here. Yeah. But what the psychologist does with cognitive behavioral therapy is try to understand the components of pain, right? When you have pain, part is a signal, but we know that these patients, when we do scopes, when we do every test that we do, they're negative, right? They're normal. So in some way, the brain is generating the pain, not making it up. I mean, this is not psychological,
Right.
but the computer is having a software problem when it's saying, okay, that signal that is coming is a threat. I need to react to this. This is concerning. When in reality, it may just be that your colon is contracting because you have to have a bowel movement.
Sure.
Right?
Sure.
But in most of the people, that signal doesn't get to your conscious level. Your brain manages responses and coordinates stuff without you being aware. When those signals get to your more conscious part of the brain interprets that as a threat in a patient with chronic pain or with these disorders.
Yeah.
And then comes the fear, and then comes the, oh, I will never get better.
Oh, yeah.
And, oh, this is going to distort my life. And the anxiety, okay, I'm going to need to poop in the middle of class, and I have only 4 passes per year that I can go to the bathroom. You know? So then what you do in cognitive behavioral therapy is try to dissect those components and say, okay, you know, I understand your symptoms, but you're also fearful. How do we work with the fear? How do we work with the anxiety component that this is producing? How do we work with you losing all your friends because you're not going to school? You know, that sense of loss. And then the psychologist reframes those signals so you can cope with them better. Would you like to add something there, Tom?
Yeah, I think you did a beautiful job explaining it. The only thing I'm going to add is just a further analogy so people understand what we're talking about.
Yeah.
And I like the house alarm analogy.
Okay.
So for pain. So the house alarm typically has 2 components. It has a signaling component. For example, if you have a motion detector, a burglar comes through the motion detector and it sends a signal, and then the central processor receives that signal and generates a loud noise. Perhaps it sends a signal to the police. Now, if you have your house alarm on bypass, then that signal is null and void. It doesn't go anywhere.
Yeah.
And so I explain this to patients by saying, we're going to try to get your brain on bypass. And the mistake I think we've made for many, many years is to think of pain as the signal, that when the burglar goes through, that signal.
Sure, yeah.
But that's not pain. Pain is the alarm being generated. Pain is the sense your brain interprets this as being a threat.
Okay.
How many times do we all bang our elbows, see a black and blue mark, and say, when did I do that?
Right.
Obviously, at that moment, your brain didn't interpret that as being a threat.
Yeah.
So it's the interpretation that Gisela talked about of this particular sensation being a threat to you as a person. That's what generates pain, not the signal itself.
Wow.
In the chronic.
Yeah, that does help you understand it when pain is yeah, that's very interesting. So lastly, when people come to your clinic, then what is what I call the ideal outcome when they get done?
So what we do is explain this. Just tell them, and when I deal with teens, explain to them that this is a software problem. They get it much better than the adults because they are so computer literate. And the other thing that we tell them, you know, I see a whole spectrum. From kids that just have the belly pain, but they're going to school, they get dizzy, but life is going on, to the kids that have been bedridden for 4 or 5 months,
right,
and they can't even get up from bed, and they come in wheelchairs. So we tell them this is a software problem. You already were scoped and had tests done by 20 people. I'm opinion number 5. You know, I'm not going to repeat those tests. They're not going to be abnormal. How do we help you? So here is, we need to work with this cognitive behavioral therapy, dissect your pain sensation, what really is that.
Sure.
But we also need to get you activated. We need to get you moving. The worst thing you can do is be in bed.
Which is what you want to do.
And what everybody as a parent does.
Yeah.
You know, your kiddo feels sick, is nauseous, is weak. Okay, sweetie, let me bring you breakfast. Just stay in bed. And then your postural tachycardia gets worse. You get deconditioned. everything gets worse. If you are bedridden, you're going to develop postural tachycardia if you didn't have it before. Your pain signals, your pain threshold decreases. You perceive pain now with much less.
Yeah.
So the first thing we need to do is let's start getting you up from bed. And
Okay.
sometimes we do baby steps. Okay, I just saw a patient the other day, and she has been bedridden. I said, okay, I want you just sitting. I'm not asking you to walk around. I just want the legs hanging down so we have that orthostatic challenge.
Right.
So you don't are totally deconditioned. The next step I'm going to do is let's get you to walk a little bit. And we work a lot with physical therapy.
And sometimes, sometimes in the water.
Yeah, and water has no
Yeah.
gravity, so water is a good place to start exercising.
And you know, it's interesting because when we're talking to some other people, this is exactly the remedy that we know of some of the people that we're going to be talking about a little later today about that whole idea of the discipline.
So let me just say a couple words about the bladder.
Okay.
And this is really for urologists and general physicians. When someone, if you're a urologist in your office and somebody comes in and they happen to have Parkinson's disease or multiple system atrophy or POTS, and these are all questions as a urologist you need to ask. Do you have a neurologic disorder in the background?
Mm-hmm.
If they do, be careful about assuming, say you have a 55-year-old male who's coming in with some urinary hesitancy, be careful about jumping to the conclusion that they have prostatic hypertrophy. My recommendation is work with the neurologist, figure out whether this is part and parcel of the neurologic syndrome they have.
Okay.
Before you jump in and do maybe a prostatic operation to try to open things up. Because if this is part of the neurologic syndrome, and this takes a lot of careful testing, probably what we call urodynamic testing and other ways of looking at how the bladder is working, and actually looking by ultrasound at the prostate and the what we call the outlet. If you don't do that, you may wind up doing an operation and you actually don't help the person. And so you have to be very careful about whether they have a pure, true structural urologic disorder or whether they have a neurologic disorder that's mimicking a structural urologic disorder. So that's one thing I would say. The other thing I would add to that is that the drugs we have available for outlet obstruction of the prostate and so on and so forth can also be very helpful if it's a neurologic problem. So by all means, give those a try. But just be aware of one thing: the urethra is a hollow tube, and it reacts pretty much identically to blood vessels, which are also hollow tubes. So if you give something that's going to dilate the urethra, and the person has orthostatic hypotension and can pass out, you're going to dilate those blood vessels.
Oh boy!
So now they're going to pass out. Or they may pass out.
Okay, yeah.
So you have to be careful about that overlap. And these are typically called alpha adrenergic blockers.
Right.
And if you use an alpha adrenergic blocker, be careful that you're working with the neurologist or with the cardiologist, whoever's managing the blood pressure, so that you're not working against each other. So that's an important point. The last point I want to make is it's not impossible to use an alpha blocker, but you have to add salt. And the urologist, I'm not telling urologists to add salt. I'm just saying be aware that you could use the alpha blocker if it's going to help them use their bladder.
Sure.
You just have to compensate a little bit by adding a little bit of salt.
Great. Did we get everything?
So the last thing we could talk about is just the connection between pelvic pain and the autonomic nervous system.
Okay, so we have to make this fairly brief. So tell me about that.
Because remember, we have twice the time.
Yes. Okay. Okay.
Yeah. So the so this is really on the just current research. We just published a paper that shows that some disorders, pain disorders of the pelvic area, namely interstitial cystitis, which is where your bladder is constantly in pain and you're constantly going to the bathroom. Some people are bladder bound, they're toilet bound. They have to always be in a place where they can go to the toilet.
Yeah.
That group seems to have an abnormality of the vagus function, whereas the group that has myofascial pelvic pain, which is where the muscles all tighten up and they have terrible pelvic pain also, seems to have an abnormality of the fight or flight system that we call the sympathetic system. And so these two disorders, while they seem or feel similar, actually we're beginning to dissect them a little bit. So it's just kind of a heads up of this is what's coming down the pike. And we may, in a couple of years, have more understanding of how these disorders differ from one another. And this is work we're doing together in an NIH-funded study.
Oh, that's wonderful. All right. Boy, I digested a lot, and I think I understand most of it. That's the amazing part. Hey, thank you for your time, and keep up the good work. We really appreciate what you do in your practice.
Thank you for having us.
Thanks for having us.